The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk.
Okay, hello everyone. Welcome back to another episode of the Success in Practice podcast. We're back here with Ann Cooper. Hopefully, me and Ann get to do a few more episodes of just having a chat and letting you guys in on how osteopaths talk when they're just hanging about and having a chat about osteopathy. And so, Anne, welcome to the podcast. If anybody doesn't know Anne, she's in Sydney, over at Central Sydney Osteopathy, and has been practicing since the late 80s, from what I understand. Anne, welcome to the show. It's good to talk to you again.
Thank you. It's good to be here again.
There's been good feedback from the first show that we did. There was even better feedback from the show that you did with me. And people really kind of have said to me that, we just enjoy hearing you guys having a chat about osteopathy, nothing too formal, and just I thought we'd do an episode where we just talk about some of the cases that we've seen in practice either recently or over the years, and talk about maybe some of the current events going on in osteopathy and what's happening. So, but before we do that, how's your hamstring?
Well, that's been an interesting thing. It's 6 months next week that I ripped it off my ischial tuberosity by doing some bird watching on the Cooks River. I don't know if last I saw you, I'd been to see a physio, and well, that confirmed everything I ever believed. He was a lovely boy, but he just told me to do quarter squats. That's it.
Right.
And that, it's ridiculous. And so I didn't do the quarter squats. I went to Central Sydney Osteopathy. I had some treatment. I had my pelvis balanced by the people there. And of course, when you rip your hamstring off, your pelvis goes up the spout. So
right.
that was a big thing. And the only exercise I do is activities of daily living and walking. And right. I walk a lot. Inadvertently, I seem to walk at least 10,000 a day. And I'm doing all right, thank you, for an old girl.
Let's talk about that. Why do you think he would have told you to do quarter squats? Like, did you
I don't know. You tell me. I don't know. Again, he was talking about strengthening. Now, this would have been 4 weeks after the surgery. There was no strengthening required. It was getting rid of edema that was required. And just waking this terribly damaged muscle up. You can imagine when you stretch it so much that it rips off the ischial tuberosity, that the fibres of the muscle are terribly, terribly damaged. There's a lot of bleeding in there. It was interesting that the surgeon told me, because I said to him, is this related to age, to menopause? And he said, certainly not, certainly not. But I think I said last time, 2 friends had the same thing happen to them that same week. One's older than me, she's 69, and the other one's only in her 50s. She was playing baseball. But I think it's a common injury in menopausal and postmenopausal women, but really we don't count that much, so it's not taken much into account.
Yeah, the quarter squats.
This guy said to me when I woke up, oh my God, the surgery.
In the squat,
surgery's
the hamstring doesn't really change too much in terms of
he
length.
said to me, hey?
I said that the hamstring in the squat doesn't change a lot in terms of length. So, I mean, if you're trying to strengthen something, you need to take it through its full range of motion, at least at what it can do. And
maybe he just had nothing really to say. Maybe he had nothing to say, and so he offered something that's anodyne and silly.
Right.
But the surgeon said to me, most people have no pain with this surgery. Really? Okay. again, dismissing what the patient said. And this is a big thing. It was interesting for it to happen to me, because one of the things I really like is treating people who haven't been heard. And this bloke, and, typical, he told me what school he went to, and, because I care. And I just think, what are you on about, mate? What are you telling me, that it doesn't hurt, or I was faking it, or whatever he was saying? It was mad. It was mad. But again, he's ignoring older people, and older people are crucial to osteopathic practice, and God, do they benefit so well, don't they? They really do benefit.
Yeah, I think the advice that you gave yourself was, you obviously had some treatment, and balanced the pelvis. You looked at the lumbars. You wanted to regain normal, I guess, movement so you could walk. And then the advice is, off you go. Just go and live as best as you can, without pain. And sometimes it'll be uncomfortable, and that's fine. But I guess that would have been the advice that would have been given 100 years ago. Just there was no rehab back then. It was like that era. It's not like there was rehabilitation. 100, 150 years ago, when osteopathy was kind of in its infancy, it would have been just treatment, and then off you go. Just go and live. And in those days, that would have made sense, because life was tough back then. Physically tough, a lot tougher than what it is now. And these days, I guess, just go and live might mean someone goes and sits behind a desk for 8 hours,
which would have been the worst possible thing. The worst for this injury, the worst possible thing. Yeah.
Yeah. And so I think there is a space there for rehabilitation. But I've had this conversation with many other practitioners on the podcast since we last spoke. There is a space there for it, but it needs to follow osteopathic principles. We need to take the same thing that we think about when we treat and apply that to the things that we tell people to do. Right? It needs to make sense. And I don't know why there's this hybrid of practitioner that thinks that osteopathy is fantastic and it works in the clinic, but when it comes to, giving people exercises, things to do, that they just follow a script or a template or a recipe. And so there's
Do you think they lack confidence?
Jade, I spoke to Jade last week, Jade Scott, and she said that they lack conviction, which means there's no belief in the osteopathic way. And I would agree with that. I think conviction, they're not really convinced that, it's going to be the thing that's going to get them out of trouble. So there's a real space there, though. Like, where you're somebody that's now moving towards the end of your career, and I'm probably in the middle of my career, and moving forward into the next 20 years, we have an opportunity. The physios, I don't think have done. It's not that they haven't done a great job, but they split the body into different bits, and they've just done what they did with, like, physiotherapy has done to rehabilitation what they did with the body in terms of how they treat it. They split it up into little bits and pieces and treat the little bits and pieces, and hopefully that makes a change. That's a bit antithetical to the way that we think. And they've just applied the same thing in terms of rehab. Chiropractors have gone another way, and they've kind of done their manipulative stuff, and then they've tried to incorporate that with kind of strength and conditioning and some Pilates and so forth. There's a real space there for osteopathy to take osteopathic principles and apply it to rehabilitation, right? And if we do that, we'll just go ahead of the game straight away, because the evidence will catch up to us in that sense. Because I
it always has.
An article. Yeah, I remember reading an article about a certain type of strength training that a former Olympic coach used to use, and he's used it for the last probably 40 years. And this coach, his name was Charles Poliquin, he's since passed away, but he used this methodology to increase strength in his athletes. And he used it over about 4 or 5 different Olympics with 28 gold medals and 28 gold medals in about 10 different fields, which is impressive. And he said that if I waited for the evidence to catch up to what I was doing, I would have missed out on all those gold medals for the athletes that I was coaching. And so that's something to think about if you're an osteopath. If we're doing things that work in the clinic, and we're waiting for evidence to catch up to us before we do them, we're going to miss out on helping a whole bunch of people.
Last night I
So,
watched a TV show. I'm spending a lot of time not watching television lately, and it was about the Columbia disaster in 2003, where the space shuttle went up, and as it was going up at 81 seconds, all the boffins saw that something had fallen off one of the engine covers, and it was foam, and they knew that it was a bad thing, and they were nowhere near the space station. But NASA wouldn't do anything about it because they hadn't had any data yet, and they literally would not allow the astronauts to look out one window to see if repairs needed to be done because they hadn't had the data. There was no evidence yet. And so when they came back in, it caught fire and they all died. And it was just exactly what we go through, exactly what we go through. If there's no data, it doesn't exist.
yeah, so I appreciate like that there is evidence on certain things, and if that evidence makes sense and it's strong and it's well done, and then yeah, by all means. But if there's nothing in front of you, if you're paving a trail, then by all means you've got to use your rationale and your thought process and some of the things that other people have done before you that have worked. There's nothing
And
wrong with
doesn't
that.
it isn't that one of the joys? Is you follow the recipe, and
Yeah,
amazing things
and
happen.
everybody puts their own twist to the recipe too, and it still works.
It's okay. It's like there's rules to
Yeah.
playing guitar, aren't there? But everybody, good guitarists, put a twist to it. They're still playing the guitar, and I
Yeah.
think the way that we treat the body is like playing guitar.
Well, let me ask you a question, and I wanted to ask this to a few people, but I haven't had the chance to yet. What do you think about talent? Like, is there a talent to doing what we do? Do you think there are talented people? I mean, does that play a role in a practitioner in terms of how talented they are? Their skill set, how they apply it, how the finesse that they do it with, and how do do you have anything to add
Gee,
to
that's
that?
such a good question. It's such a good question. I've never thought about it, but I couldn't say that there are people with talent, but gee whiz, I've seen people who just never got it, and they just didn't have the dexterity. I mean, I'm hardly dexterous, but they just didn't have it, and they didn't have the ability to do the kind of osteopathy that I wanted to see. So maybe they went to other parts of osteopathy. I don't know. Maybe they just stuck in the theory and went to academia or something like that. But I do look. There's talent in every other field. I
Yeah.
follow I literally follow a cooking recipe and I stuff it up. There's just no way. Whereas my partner follows a recipe and you get the most amazing meal. I have no talent, and
Right.
I do think, since you say that, yeah, maybe there is talent, and of course there is. There is in every other field.
There has to be. I mean, there's talent. There's got to be some genetic predisposition to what we do, I think,
Well,
in
it could be
terms of,
it could be not so much genetic, but just an ability. Like I can play Layla on the guitar, but so can Eric Clapton. And there's a difference here, isn't it? We're playing the same thing.
well, I mean, yeah, but you haven't put the hours in that he has. I mean, I'm not
Well,
talking about practice. Well, there's
Yeah.
people that just do it for a long time and they're good practitioners. But then there are superstars that don't do it for a long time and are still good practitioners. They've got talent. You see them. I've seen them. They're talented people, and they seem to. Time is always going to be a factor, but I've seen some practitioners that it's 10 years on, they're still struggling. I've seen others 2 years into it and they're cracking the whip and they're doing really well.
I know.
There might be
Why do you
something
think
to
the
do with
ones that are
thought
10 years
process.
on are struggling? Why do you think they're struggling?
This is just my opinion. I would say a combination of probably volume. I think volume's important. I think if you get just stuck treating, on an hour list, I think you're not gonna see as many people. And the problem with that is that you don't end up backing yourself in terms of what you want to do. So, if I see patient with a certain problem and I've diagnosed that correctly, and then I've applied treatment to the diagnosis that I've diagnosed, and then I'm going to see if that treatment works. But if I'm seeing somebody for an hour and I'm doing the whole thing, if I'm just treating everything, I don't know what's working and what's not. And so you start to build these kind of patterns in your brain, and then you go and you refine those, and then you can start being a bit more maybe meticulous with what you do, and then that's how your talent grows. So that's one of the things I think.
But that's not talent, is it? That's skill.
Yeah, skill. That's right. But you've got to. The question you asked is, why do you think practitioners, go for 10 years and still don't? I guess they don't back themselves to build up that skill set.
And I'd agree with that. I think they have a foot in both camps. They haven't committed. They haven't committed to what they're doing.
Yeah,
which is osteopathic medicine.
That's why I said that they're not backing themselves. And I think another one is also just I think being alone in practice is not great.
Nasty.
I think having people around you, and sometimes it's hard, but also having colleagues that you can bounce things off. Bringing up someone and having a chat to them, just making sure that you don't just think you're the be all and end all of everything. I think
having colleagues also, it's not just bouncing things off them. There's obviously competition. When there's a group practice, everybody knows how much everybody else is seeing and making. They know it, and no one wants to be in the bottom. And so there's a level of competition, and I think it's a healthy competition that makes them want to climb that ladder. And I think that's really, really good. Now, if it's a generous practice where they're sharing their experiences, everyone gets there if they want. Which isn't to say that if they're failing, it's because they want to fail. I'm just saying that if people really want to work in a way that's effective and clients like it, they'll get where they want to be, financially and in terms of numbers and in terms of the joy that patient care gives you.
Yeah, definitely. And so, the whole 10-year thing where people maybe don't get there as much, but there's different levels, and it's not for everybody. I mean, some people are just going to be happy at a certain level and that's it, right? And then they may not. That's why I say volume is important. I think, treating 30 or 40 patients a week for the rest of your career is going to take you somewhere, and then treating 60, 70 plus a week is going to take you somewhere else, and then treating 100 a week is going to take you to another place.
That's a graveyard, yes, the graveyard.
Yeah. Well, if you know how to do it properly. If you don't, it's hard work. It's not, but some people enjoy. Like I enjoy it. If I'm not doing that, I'm just not. I enjoy that volume. Is it tough on the body? Definitely, but it's not for everybody. I wouldn't recommend a lot of like if you're not able-bodied, if you're not strong. I wouldn't recommend that happens. But I think though, the 60, 70 plus a week is a really good place to aim. And I spoke to Fiona Pete a few weeks ago about this, and she mentioned a time in her career where she was just working a lot and was doing 60 to 70 clients a week. And then she said that she backed off from that over the years, and now she's just taking it easy. But she's really enjoying kind of just being able to pick things out and talk to patients and know what she has to do. And I said to her, you're finding things a lot easier now because back in the day, you did that volume that got you to the place where you understand things and you can do things at a quick recall. And so I think that type of volume is important. Whether you just go through it for a certain period of your career or whether you continue to do it, it doesn't really matter. But I think being able to get there and get there well and be able to help people, I think it's important. It will teach you a lot of things. So that's the answer to that.
I think when you first start, you have to give it everything. When you first start, you have to give it everything. You have to be around. You have to be available. You have to reach a certain level, and it's only then where Fiona was able to say, right, I'm backing off now. I'm just going to sail along. You get your momentum up and then you sail along. And you've got your reputation and you see people that you haven't seen for years who still talk about you and still are grateful to you. You know, I saw one of those today in the waiting room. So, yeah, you have to, I mean, money is just energy. It's just transformed energy. And you can have too much energy. That's what obesity is. You can be a beast financially as well as physically. You have to find your correct weight. And that I went weight in terms of your own body and your own strength and how much money you want. No, that's why I say the young ones at work, think about how much money you want without getting sick, without your chest complaining. I mean, the amount of osteopaths, especially the men who get pneumonia, is really interesting. I know 3 or 4 men I know who fit as trouts and they suddenly develop pneumonia. And that's because they're working too hard. So you have to find that balance.
Why do you think that is, though?
Oh, I think they're doing wing lifts. I think wing lifts are shocking things. I mean, how could putting 100 kilos on your sternum, behind which sits your lung and your heart and of course the thoracic duct, how could that possibly be a good thing? And I don't know. I remember when I was nursing, we had a radiologist come in and talk to us, and he put this X-ray up, and it was obviously pneumonia. It was all white and cloudy, and he said, "What's this?" And we said pneumonia, and he said, "No, this is grief." It's really interesting. So, you know, who knows? Maybe that's a part of what goes on too, because we know that men aren't very good at expressing emotions when they need to. So maybe it was that. I don't know.
Yeah, right. And I heard something interesting is that, you know, you fall to the level of your training. You know, like when you're having an off day, you know, you fall to the level of your training. And I guess when you're a young practitioner, that's when your training starts in those first 2, 3, 4 years of practice. And so if you can get to that level, a higher level in those first 3 or 4 years of practice, sometimes you'll have an off day, but you'll fall to that level. If that level is still great, you'll be fine.
Yeah, and that's what I see with the young ones at work. It's lovely to see that the patients are coming out and saying, "That was great. Thank you, Bridie.
Yeah.
Thank you, so-and-so." You know, they're saying
Yeah, do you ever see it where, you know, the patients come out and said, "Oh, that was fantastic," but the practitioners come and saw you and said, "Oh, geez, that was a rough one. Wasn't, you know, like..."
Which just means they had to put more thought into it, didn't it?
Yeah.
Yeah.
I want to ask you a question. I had a conversation with Alison Lynn, and we were talking after we recorded our podcast. She said to me, she goes, "You know what would be an interesting episode? We should do an episode on how to manage the creepy patient."
Yes. Well, the creepy patient means, yes. And I'm actually going to organise a podcast, not a podcast, but a webcast or whatever you call it, with a psychologist who specialises in psychopathy, because we've had some incidents at my work recently, which it's just been ringing alarm bells for me. And I've said, you know, we've got to stop seeing this patient, or we've got to modify the way that we're seeing this patient. And the people just didn't understand and said, "You have no idea how much danger you're in with these people." But there are certain recognisable traits that these people have, psychopaths and narcissists. And, you know, even when I was young, I had a few people try to come on to me. And one said, "If you don't go out with me, I'm going to report you to whoever it was in those days."
Yeah.
I said, "Go ahead, love. I don't care. Go ahead." But I certainly made a point of making a note of it. So we're going to do that, have a webcast with a psychologist talking about how to recognise what they do, because they're very predictable, psychopaths. They're very smart, but their behaviour is very predictable. So we'll be doing that in February, and I hope other people listen. People all over Australia, especially the ones in the country, because, well, maybe it should be you. You can just interview her. Doesn't have to be me.
We could do that. We could have her on the podcast and do an episode.
I think that's a really good idea.
And then we can put that up as a webinar. I think you meant to say webinar.
Okay.
So we can have that with live people attending live as well, and do that as a webinar.
I think it's probably better to get you to do it than me to try to do it. But I had a long talk to her last week about this because I was quite shaken by what I was seeing at work and the gormlessness of the people at work who just didn't. And why would they know how much danger they're in? But I've seen this. I've seen this on the national board, and I've seen it on the New South Wales Council. How men, it's usually men, can get trapped, and a lot of them really are just like rabbits in a headlight, and because they're young men and we are literally putting our arms around people, and we're being nice to them. There's an awful lot of lonely people out there.
Yeah, I remember having an incident actually when I remember working with yourself over at I don't know if you remember this, over at Newtown, and I walked into I was I think 2 years graduated, or a year and a half, about a year and a half, and I walked into the room and the lady just laying down there stark naked on the bed.
Because it's so attractive, isn't it?
Right, and I guess, I mean, she wasn't an unattractive lady, right? But she's just laying there and just took me back, right? And then I remember coming out and speaking to you about it. I said, what do I do? Like, I've just had to excuse myself and walk out. And you said to me, you said, look, just take it easy. Don't say anything to piss her off. Because, you said to me, go make a note of it and tell the receptionist, let her make a note of it, and go in there and ask her to just politely put something on just due to hygiene reasons. And I thought that was great advice because, the last thing you want to do is to, have someone scream something that's untrue about you because you've just let the steam out of your ears and gone off at them.
Because you've rejected them.
But do you think that
they have the power?
Do you think though that, I mean, me being a male handling that would be different than how a female would handle it? Like, had the roles been reversed,
Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
Yeah, I just feel disgust. But I try not to show it, which is very hard for me. But do
you think men and women should handle it differently? I mean, given...
No, I think when we've had men sexually approach women, I've just chucked them out. I've just told them to leave, and it wasn't.
So would you do the same thing though to a woman that approaches a man that way? Like, I mean, that wasn't your advice back then. I remember you saying, "Look, don't, just
you're more vulnerable. You're much more vulnerable."
Yeah. Yeah.
Absolutely, because men are regarded, and quite rightly, because how many women are we up to this year murdered in their own homes? That men are regarded as the aggressors, and there's good reason for that. But it's you don't want it to go to the council, or you don't want it to go to the HCCC or APRA. You just don't want it to. But the men were being sexually provocative, and so they really would have had no defence. But it's very hard for a woman to. It's very easy for a woman to say, "He touched me." He said terrible things. I had a patient. An osteopath ring me this week and complaining about an osteopath in her town, and who'd been asking about penis size, what women like, and I hope that he gets reported to whoever it is that it gets reported to in that state. But it's unbelievable that these people in their own domain, because they're in their own treatment room and they really think they're the king of the castle, and that they can do anything they want. It's unbelievable that they think they should get away with it. And a lot of the time they do, and then one day they won't.
Yeah, well, I think we'll get Alison on another episode and have that discussion, because I think there are some practical tips out there, but I think also we'll speak to this. Is it the psychologist that you want to have on?
Yeah, Soraya Mir.
Yeah, we'll do that. We'll do an episode with them. And so, okay, well, I want to give you. I want to discuss with you a recent, I guess, experience I had. I went and caught up with some of my old buddies from university on the sidelines of the recent osteopathy conference in Sydney, and that was great seeing people that I studied with, more than 20 years ago.
Are they all happy and well, Sammy? Are they all happy and satisfied
the ones that
in
were
their
there,
jobs?
the ones that were there were. They seem to be, and I'm sure they are. They're genuine, honest people. And I guess I did get to have a chat though to a few other people who I didn't study with, but who are also there at the same pub, I guess, or place, having a meal and having a drink. And it's interesting talking to people who are of different vintages, because a few of them, we had this conversation, and a few of them, we talked about kind of how osteopathy was traveling in terms of a profession, and the identity of osteopaths and osteopathy. And it was a bit of a mixed bunch, because some of them were understanding that we are unique and we have a point of difference. Yet there was a couple of them, and these aren't new graduates. These are people that have been practicing longer than me, who felt that it wasn't a big problem if we lose our identity, as long as we're kind of doing the right thing by the patient. They were kind of like, well, if the movement in healthcare is to bring all these different modalities together into kind of one molded modality of physical therapy, or whatever you want to call it, we don't really care as long as the patient gets better. Why shouldn't we steal things from physiotherapy, and why shouldn't physiotherapy steal things from us, and or borrow or take, or why shouldn't we all just share knowledge and have what's best for the patient? So that was an interesting discussion, and I want to get your thoughts on that. I mean, why don't we just all amalgamate into this one kind of happy place where we borrow each other's stuff and just do what's best for the patient?
Because osteopathy isn't physical therapy, it's a system of medicine where we're trying to influence the health of the individual at a very basic homeostatic level. We're trying to make the liver work better, the spleen work better, the bowel work better, the brain work better, the lungs work better. We're looking for health. We're not looking for mobility of the hip. We're not separating the shoulder from the rib cage, and we're not separating the rib cage from the lung function, and therefore the diaphragm and the spleen and the liver and the gallbladder and the pancreas. We are practicing a system of medicine. And that's very radical stuff. It's offensive to many people because they don't understand it. But that's okay. It's okay that they don't understand it. It doesn't take much to explain why osteopathy is a system of medicine, and why mechanical manipulation and reduction of pressure would make a hydraulic system work better. But this is the problem, is that as long as we are forever having to cut our edges and reduce ourselves to look the same as the others, we're losing our medicine. We're losing what we are, which is, as I keep saying it, it's a system of medicine. Physiotherapy.
And so, what's the problem? Their argument though is, what's the problem with that? Like, why are we so clingy to our identity if what we're supposed to be here is for the patient? Like, we're supposed to be here to help the patient. Why are we so enamored with being called osteopaths or whatever we want to be called? And why don't we just share all the information with everybody?
Because they don't believe it anyway. They think the shoulder is separate. Well, we all see it in workers' compensation. They think the shoulder is separate to the ribs, is separate to the neck, is separate to the lumbar spine. You and I, with even the good anatomy that osteopaths are taught, but even basic anatomy says that the shoulder is directly connected to the tip of the sacrum and to the coccyx. We know that. We know it's a mechanical thing, but for some reason they choose to ignore it. They say the shoulder is a different thing to everything, or whatever it may be. The knee is separate to the hip. 2 separate areas, 3 separate areas. Let them say that, but we know that you can't fix a knee unless you look at the hip, and you can't fix an ankle unless you look at the knee, and then you look at the hip, and then you look at the lumbars, and if you're going to look at the lumbars, you better look at everything that attaches to the lumbars, and then we're up at the shoulder again. Then before you know it, you're at the occiput. We know that, and we know that you can't fix people without doing that. But while we do like the income that osteopaths get, we're not doing this for the money. If we wanted to do it for the money, we'd be in some other gig. I guess it was less physically demanding. But when we don't have to do that. We don't have to tell lies and biological stupidities. We're living in a world at the moment where we're all being gaslighted. We're being told that black is white and white is black, and that men are women and women are men. We're being told that truth is lies and lies is truth. Everyone's discombobulated, and that's why the West is, I think, in a bit of a mess. That rhymes, isn't it? Like Dr. Seuss. But we know that that's a fact. Latissimus dorsi, trapezius. We know what they are, and they're just the superficial bits. They're not the deepest bits. And we have to stick to the truth. And there's a comfort in being truthful. There's a real comfort in there. We don't have to prove anything and we don't have to shout it loud from the tops, the rooftops, because we just have to listen to our patients and see what they're saying. But first of all, you must listen to them and really understand. Menopausal women get bad shoulders. They get a frozen shoulder. Now, who knows why that's? I'm no endocrinologist, and I don't really understand. Of course, I don't understand endocrinology. But when I had a frozen shoulder, which I developed a couple of months after going skiing, last time I went skiing, and fell on my shoulder, I saw Jordan Rosewarne at our clinic, my clinic, and the thing that finally broke that was a lumbar adjustment and an elbow adjustment. Both those things in the same treatment, bingo, completely free shoulder. Jordan was a relatively new grad at the time, but he'd asked to come and work at CSO because he wanted to learn something that he knew that we had to offer him. And not just me, it was the others there too. And he knew that there was more to this than just core stability. And the absurdity of saying, someone said to me the other day, I've got bursitis. Or bursitis just means that something's pressing down on the bursa and it gets inflamed. In itself, it's not a diagnosis. It's just a consequence of a strain pattern that's involving the glenohumeral joint. It doesn't solve the problem to say you've got bursitis or anythingitis. we have to find out what it is that's causing that inflammation. And while we're there, let's ask about someone's health. I remember a woman coming to see me once, and she was in her 70s. Her husband had died about 6 months before, and she had pancreatitis. She went to Camden Hospital. I remember these details. Camden Hospital, and they said, well, how much do you drink? And she said, I don't drink. And they said, you do drink because you got pancreatitis. She said, I don't drink. And she said, and they kept me in there, and it dissipated, but, basically they just kept me in there and insisting that I stop drinking. And I said, well, what had you been doing that day? And she said, I had to mow the bloody lawn for the first time since my husband died. I had to mow the lawn. And it was one of those pull mowers, and she had to pull on it. She said, I literally pulled on it 60 times. And you can imagine what that did to her thoracic cage, to her TL. And you can imagine why it would have caused, in a quite slightly built woman, a deep inflammation, or rather congestion and then inflammation of organs deep inside her, right in the middle of her body, at the fulcrum of her body, of her thorax. That's beautiful stuff to think and treat accordingly. Beautiful stuff. They're not going to think about that. They're going to say she drinks too much, or it's idiopathic, which is idiotic. Always this word, idiopathic.
So then do we operate kind of like on that, in that 10% of the outliers? I mean, is that when osteopathy does its best work? Where people
they're the ones that come to us at the end, when they're at the end of their... I don't know why this woman came to see me. She must have been referred by someone who's referred by someone who referred by someone, but because she was from Whoop Whoop. But most people come because they've been told to come and see us. Now, your Facebook feed, even though you're young, will be full of people telling you how to increase your patient numbers. And the first thing they say is, don't rely on patient testimonials or referrals. Well, I beg to disagree. I think that's where our practice grows. And I don't. What do you think? I don't think it's because of Facebook. I don't think it's. I mean, anyone that goes to see an osteopath because of what they see on Instagram that's mental, isn't it?
Yeah.
That's just pure advertising. You can only go on something you trust.
A good marketer or a good advertiser will get you one lead. What we call a lead. Right? Somebody, they'll get you a lead. A good osteopath will get you 10 from that one lead. A good osteopath will know how to get 10 referrals from that one lead. And so there's nothing wrong with getting the one lead. But, people online that sell you this stuff, they don't know if you're a good osteopath or not. And I guess that's why those ads come up for you.
I don't think they care whether you're a good osteopath or not, because their focus is about making money.
They don't care. But the people who are listening out there, the young practitioners, they should care that they're good osteopaths, because it is the easiest way to grow your practice. It is still the easiest way to grow your practice. And I've been having discussions with people who are fantastic business people, as well as being osteopaths. And they still agree that the best way to grow your patient list is to take the ones that you have, apply osteopathy, and obviously your personality needs to shine through. I spoke to Jess Harvey a couple of weeks ago. She's up in Brisbane, and she said that. She goes, osteopathy is great. We learn it, we apply it, but if you let your personality shine through that, that's when you'll really start to see people not only refer to you, but you'll like the kind of the patient list that you have. And you'll enjoy your practice. And I thought
which has made it so easy for me, because my personality is so sparkling, isn't it?
Well, I guess you know how to say no. This doesn't sound right. Let's go looking here and there. You're not a go with the flow kind of person. And I think that makes for a good practitioner, because you start questioning things. You start asking questions, and they take you down rabbit holes that no one else has been. You get to help people that no one else can help.
But I do agree, and I say to the young ones, when they tell you there's a diagnosis and it's using Greco-Latin terminology on their patient sheet that they filled out, don't believe it. Let's just ask about that. asthma, for example, sinusitis, for example, constipation, a period pain. All these things are things that we can manage quite well. And we do often manage quite well, rather. We don't always, but we often do. But just don't take for granted that the medical diagnosis is definitive. Take it back, break that medical diagnosis back into its some parts and see what happened to make this thing happen. Like the woman who, when I said, what were you doing that day? Pulling 60 times on a rope on a lawnmower, which didn't work. Yeah, it makes sense, doesn't it?
Yeah, I had a sinusitis patient actually this week. Yeah, lovely little young lady, well, not a young lady, she's an older lady actually, from a grandmother she's from the Philippines, and she had developed some neck pain many months ago, and that dissipated. The neck pain went away, but she had this bogginess in her head, and she thought it was just hay fever. She put down a hay fever, and she'd been to see doctors and GPs about it and so forth, and they gave her all the tablets, and she ended up getting some cortisone as well for it, and it just wouldn't go away.
Oh, breathe
Her
in
sinus.
thing.
So she had this fullness in behind her eyes and over her cheeks, and she just said, "My face feels full." And I said, okay, well, is there anything else? I mean, what are you here to see me for? We had a chat. She had some neck pain and some headaches and so forth. So we treated that during the first session. I treated that, and her neck pain and headache largely calmed down. And then I asked her about the fullness in her face. She said, "Oh, look, no, that's a little bit better, but it's not totally gone." I said, "Well, have a lay down." And I said, "Let's." I put a glove on and put my finger in and did a bit of massage on it, did a fascial release on that soft palate. And she came back the following week and said, "Oh, it's gone. It's been there. It's been there for 5 months and it's gone." And so, that was just, I guess, an example of just allowing that sinus cavity to drain away. And I think had I just done the soft palate release without adjusting the thoracics, I don't think it would have worked.
Of course not, because it had to.
You got to get that thoracic area.
It has to be able to drain. The pressure in the lungs.
That thoracic duct needs to accept the fluid that you're trying to get out of that, or the pressure or whatever it is that's in that sinus has to be able to go somewhere. Well, the pressure
in the thoracic cage has to be lower than the pressure in the head and in the neck. And if you have a torsion head, which we do get, and if you have certainly a compressed and torsion neck, then it's not going to drain down into the lower pressure. It's just a pressure gradient of the thorax. But what you do, so if I was a traditional type of musculoskeletal person, I would say that what Sammy did then is he massaged the inside of the soft palate and stuff like that, and it all drained away. But it's more than that, isn't it? It's, you were actually accessing the trigeminal nerve,
the parasympathetics there, yeah.
And the sympathetics make them open up, the parasympathetics do, but the cranial nerve, trigeminal nerve, you were actually releasing part of that, the tension on that. I mean, again, you'd want to say, "Oh, what's happened here? What happened about a year ago that made your body unable to compensate?" But you were performing a medical act. It wasn't a musculoskeletal act. It was a medical act that you were doing. I remember when Ian Cassidy came to me in the first years. Ian Cassidy's, a magnificent practice and a magnificent osteopath, and he's down in Wollongong. And he'd done exercise physiology before he did osteopathy, and God knows what made him do osteopathy. Well, I know he was very unhappy doing exercise physiology. He was treating a plumber in the gym at Wollongong University where he was working, and the plumber had I think a sore elbow, and they were telling him his problem was a strength problem. And so they said, you have to do whatever you have to do 50 times. And he said nothing was changing. It just wasn't working. And so they increased it to 75 and then to 100. And he said this plumber was crying with pain, and he was doing what he was told. And he said, then I knew that we were on the wrong track. So anyway, to test me in those first few days of few lessons of UWS in whatever year it was, 1998, he came to me and he said, I've got a patient who's got shin splints. And I said, oh, yeah, well, that's a fibula head. You know, it's stupid arrogance from me, but nevertheless, I was correct. He said, what do you mean? I said, well, you know, the fibula attaches through the membrane to the tibia, and they have to move like that, and that becomes a pump. And if that pump is disturbed because the fibula or the tibia or the ankle or the knee are disturbed, if that pump doesn't work, you'll get congestion. And you can exercise as much as you want, but you actually have to mobilise correctly the tibia and the fibula. And he looked at me disbelieving. Well, you know the answer. He came back next week and he was a convert. He was an absolute convert because it had all just disappeared with literally the rocking and rolling of the fibula and the tibia, naturally, like making a French roll. That's medicine. That's medicine. That's not musculoskeletal therapy, because we know, as talking about the thoracic duct, as you were, that's getting lymphatics back up through the pelvis into the thoracic duct, all the way up to the cisterna chyli, up to the left side of the neck, and then back into the lung. You know, what are we if we are not a hydraulic system?
So, are we teaching this all wrong in terms of teaching it as musculoskeletal? Like, should we be teaching it as a system of medicine?
Oh, absolutely. It's no fun otherwise. And it doesn't make sense otherwise, because if you treat it just as a musculoskeletal therapy, you will get things happen that surprise you, but you won't know why, and you'll think it was just fortuitous or an accidental finding. Well, you know yourself that if you say, well, yeah, you've got sinusitis, I'm going to look at the hydraulics of your system, going from your sphenopalatine nexus or whatever they call that thing at the back up there, all the way down to the lung, especially the thoracic cage and the sternum, then you can predict next time that the next time someone comes in, you can help them. But if you don't take any notice of these findings, these results that happen, you think it's just serendipitous, then you're not learning anything, are you?
No, definitely not. All right, so I guess one of the other conversations that I had on the sidelines of that was that, you know, people had listened into part of our conversation, and where you mentioned that, you know, we were too caught up with regulation, you know, and that if we weren't so caught up with regulation, we could probably teach what we wanted to teach and hold on to a lot of the tenets of osteopathy. I guess, you know, you weren't very popular with that particular comment, and I guess that would probably. I think that would probably be true across the board of the profession. Like if you got up there and said to the current registered osteopaths that, you know, we shouldn't really be too concerned with registration. This is Ann Cooper, who's been registered for as long as you've been registered for, and you've had your career, and you're telling these young practitioners who are, you know, 5+, 10 years out, that they should sacrifice their registration so we can keep osteopathy. They probably want to, you know, haul you out of there pretty quick.
I don't mean we sacrifice it, but I don't think, you know, we don't want to throw the baby out with the bathwater either. Or maybe we do have to throw the baby out with the bathwater. I don't know what I'm saying here. I'm just saying that registration should, if it restricts us practicing osteopathy, then what should go, the osteopathy or the registration? One of us allows to keep making a living and be respected by the people we need to be respected by, and that is our patients. And the other has us thinking that we're respected by other professionals. And you know what? We're not. They still think that I don't know what they think we are. I heard someone the other day saying, we don't believe in a GP, we don't believe in alternative therapy. I just bang my head against the wall. And we very tersely say we're not alternative therapies, we're allied health. We're not even allied health. We're not allied with them. Very rarely is osteopathy allied with medical science in terms of medical practice, scientific practice. We're just not. Very few. Some doctors kind of get it, but not many. Not many.
How do you
So
think the
we might
Americans
have to
make
make
it
a choice.
work?
Well, they don't. They don't
How
practice
do you think the
osteopathy.
Americans make it work with their system in terms of the, being doctors and osteopaths, being MDs and osteopaths at the same time?
Well, you've got to remember that they're the lower grade of doctor in the United States. They're regarded as a lower iteration of medicine. Having said that, as I think I said last time, the American president's doctor is always an osteopath by tradition. But I don't think they practice osteopathy. I don't think they do. I think they
Right.
do it as they do a bit of musculoskeletal stuff, but I remember listening to one talk about being in church and listening, and his neighbour, the person sitting next to him in the church, was burping all the time, and he said, "Oh, I won't do the American accent. I think you might have a bit of gallbladder issues." And the guy said, "Oh, no, I'm fine." This guy said to the neighbour while they were in church, "I think you should go and get it checked." So he went and got it checked, and bingo, he had gallbladder issues, and he was really chuffed with himself. And I was in the audience, and I said, "So what did you do?" And he said, "Well, I prescribed antacids." No, it wasn't gallbladder. It was gastritis. I prescribed antacids. I mean,
Okay.
an osteopath would treat that.
Yeah.
So I
Look,
don't think, and that's
do
a
you
famous
think
one.
do you think though that you can apply osteopathy to pharmacology?
Oh, look, I don't think we should ever reject modern medicine. When I get run over by a bus or when I rip my hamstring off, I'm not going to go and see an osteopath to get that repaired.
Yeah, I
And
get
when
that bit, but I understand that. But in terms of pharmacology, something that's, I guess, non-natural medicine. Do you think that you can apply, if you're a GP, if you're an MD, and you've got the disposal of pharmacology at your fingertips, do you think that you can apply the principles of osteopathy to do that rationally?
I think so. And the proof
Yeah.
is of the pudding is in the eating, isn't it? I mean, look at our lifespan now. I'm supposed to live to 85. You're supposed to live to 83. And in the 1920s, you'd be lucky to get to 38 to 50. In the 19th century, it was much worse. Now, that's medication, and it's medication and surgery, but surgery didn't get anywhere without medication because they had to have anaesthetics, they had to have antibiotics. So, we embrace what's good and what has effect, and that includes us. That includes us.
And so,
And they don't
I guess,
exclude each other.
yeah. No. And so I just want to get your thoughts on that. But moving on from that, there's been some recent media attention in terms of osteopaths being able to refer directly to specialists, to
Only
orthopedic
musculoskeletal
surgeons.
specialists. Only
Yeah,
the surgeons.
orthopedic specialists. And so that's obviously a good thing for us to be able to bypass that particular avenue of having to see the GP. But I guess the logical thing along with that is then why wouldn't you then allow for MRIs and better imaging rights? Because the first thing you got to do, well, the first thing that I do when I have to refer somebody to say a knee specialist is to say, make sure you have the MRI and the load-bearing X-ray that you got to take with you. And so I'm going to send them off to the GP to get all that stuff anyway. So, I mean, the logical thing would be then to say, well, give me the ability to order orthopedic imaging so that I can actually make a better
Well, you remember
judgment.
the GP can't order an MRI either unless it's a child under 12 or under 10.
Well,
So
the GP
the
can,
government's
it'll get
getting us to pay for our care.
Yeah, I think the current rule on that is that if they're between the age of 16 and 49, and there's a meniscus problem that's specifically written down in the referral, a GP
Oh,
can
right.
refer for an MRI that gets bulk billed,
Right, I didn't know that.
right? But and
That
so
was
there are certain
convoluted.
things that but I think there's an element of control over that too, right? Like the GPs will probably want to keep control of that particular aspect of patient care. But obviously, it's a good thing that this has happened. It's this wouldn't happen if we were not regulated, right? Like if we weren't regulated, you wouldn't have something like this come along.
Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So, for more information, please see the show notes. Now, enjoy and back to the show.
Oh, I'm not saying we shouldn't be regulated. Oh, it's good to be regulated, but if we lost it, we'd be okay. I firmly believe we'd be okay. We weren't regulated for the first half of my career, and we were fine. Unless it was a thing where you were sent to the New South Wales Osteopathy Board, it was called in those days. But I don't think we were really regulated. But of course, let's be regulated. But if we lost it, we'd be fine. I'm sure we would be fine if you practiced differently to all the other players in the market, which is the chiros and the physios, and now the exercise physiologists and the massage therapists. If you point out and display your point of difference and the skills and the insight that osteopathic medicine gives us, you'll have better results. And you'll be able to explain to people why they have, say, a headache in the morning and why they have 2 sore feet when their back is sore, and why they have shin splints or whatever it may be. You'll be able to explain those things, and no one else can do that. Maybe the chiros can, but I don't think anyone else can do that.
Yeah, I was. I guess we discussed earlier about being able to be replaced by AI, and one of the things that I've done recently in my practice is I've got this little program that's based on AI, and I've been teaching it osteopathy, right? And so it then can write some content that's very, very relevant as an osteopath, and then I can just tweak it and make it sound like me. It's absolutely amazing. It's really, really amazing what this thing can put out. And I guess then the where I'm taking this is that, will AI eventually be able to replace, certain therapies that are around? And I know that recently the ChatGPT, the main AI engine that's out at the moment, has taken the medical board exam in America and passed it. Right, it actually passed the medical board exam, which is a very difficult exam, and that just blew my mind. But I can get AI to write like me, in my own voice. And so, do you think that AI could possibly ever replace what we do?
I think when I first spoke to you, I talked about that you give and you receive love. It's a corny word when you treat people. But you do, and I'm not sure AI can treat people. I mean, it's a program, so it doesn't matter. But you mean a robot or something? It'd have to be a good robot.
I'm just thinking, it could. I mean, you just talked about physiotherapy and exercise physiology, and I guess it could probably dish out exercises. I mean, if
that's what they're doing.
You put enough recipes in there.
Yeah.
If you put enough recipes in there and you give it an itis, it'll just spurt something out. So maybe a few of those professions might have something to worry about.
You type in sore knee and it'll tell you how to treat your sore knee. Sore knee with lateral pain or whatever it was. Maybe, but it's not going to connect the knee to the pelvis. And it's not going to lay its hands on you, and it's not going to ask you how your kids are and mean something. It's not going to say, and who's your wife, Steph? Is it, how's she going? Someone you haven't seen for 15 years. It's not going to provide that human loving interaction, which we do.
Yeah, I think you're right. It's not going to provide that human interaction, but it'll definitely learn to ask, I think, about your family and friends and things like that. I think where it can't replace us is where it can actually apply the philosophy and then do the actual physical treatment. And there's an element of touch that goes along with that. And like you said, there's a transfer of energy there from the patient to the practitioner. And I think that that's just something that has to happen with hands-on therapy, right? And the problem with moving away from hands-on therapy, and this is, I know the physio courses that are being taught right now have no manual therapy involved in them, and I hope that eventually osteopathy doesn't go that way. But the hands-on aspect of osteopathy is a point of difference, and that's something that I think needs to be maintained. Otherwise, we'll get replaced. I mean, you can teach it to think like an osteopath. Because I say that because we always say it's not complicated what we do, right?
No.
Like, if you speak to a plumber, they'll tell you straight away where the blockage is in your house. It's not.
And you can be the
complicated.
village idiot and be a competent osteopath. You won't be a very good one, but you can get by. But if you're smart and if you're analytical and if you really listen to what patients are saying, and I know this is what you're like, then you're a great practitioner. You're a great facet of your community. Because that's a big thing. I mean, I guess you say we could get robots to do the massage, but I guess, you sit in one of those massage chairs and you don't feel loved. As long as we've got skin, and as long as we've got nerves, and as long as we've got oxytocin, I think, we're pretty safe in terms of not being replaced by ChatGTP. But medical doctors are, because we've all seen doctors who are just perplexed when you say something. There's nowhere for them to go, and they're busy typing while you're talking to them, and a lot of the time they're looking up what they should do. They don't know.
Well, yeah, I don't see it too far into the future. I think where you make a phone call, you speak to a computer, you tell it what's wrong with you, it gives you a diagnosis and gives you a script. And off you go.
It's all about getting the script, isn't it? I had a friend the other day. He's not a patient, but he went to get his calcium score done because his brother's calcium score was sky high, and Michael's calcium score was 20, and his cholesterol was 3, and the GP said, "I want you to go on statins." And I said, "Michael, get a new GP. That's just utter rubbish. He just wants you to come back every 3 to 6 months. That's ridiculous. You have to have fats circulating in your system to carry your hormones. It's a sad thing.
I think there's the amount of men that are on statins that shouldn't be on statins is huge, shocking. I think the evidence for it at the moment is there's only good evidence for statins if you've had a previous heart incident and you're between a certain age.
And it doesn't help women. They
doesn't
don't
help women,
women.
no. If you're a man of a certain age and you've had a previous heart incident, then you're a candidate for statins. But outside of that, I mean, you go and see your doctor and your cholesterol's a bit high and they put you on the statins straight away. And it does awful things to their tissues. Like they just, headaches and upper back and neck, their muscles turn into rocks on these statins, and it's a hard conversation to have with men as well, because it's a scary thing to think about. Imagine you're a 48-year-old man and you've got, 3-4 young kids at home, and the doctor scares the living shit out of you that you're going to have a heart attack and die. And they'll go, "Look, take these." And you just, "No problem, mate. I'll take whatever you give me," And so having that chat to them, say, "Look, your shoulder pain, your headaches, I've been doing this for 20 years and I can get tissues to let go. Your tissues aren't letting go. You're on these statins. Go and have a chat to your GP about it. Maybe have a look at the dosage or something. But, I can't get them off it. It's not my job." But I definitely send them back to their GP to have a chat. And more often than not, either the dosage gets lowered or they change the medication and the tissues just free up and let go within a week or two. And so, the amount of men there that are being affected is huge. And I guess speaking to that too, I want to ask you, obviously with the reason why I moved on to this is because, and you mentioned earlier that the medical doctor of the President of the United States is traditionally an osteopath. And given the recent elections in America and, Trump getting back into the presidency and, I mean, he was there 4 years ago and the world didn't end. So, make that of what you will.
It's still
But
time.
he's just appointed his health secretary as Robert Kennedy Jr. And he's been somebody that's been highly outspoken against the overprescription of medication, the pesticide industry, the pharmacological industrial complex. He's been quite outspoken on that and wanting to kind of hold that back to, I guess, more logical levels. Do you think that's a good thing? Do you think that'll flow on to the rest of the world?
Well, he's not
If it happens.
he's got no medical training. He wants to get rid of fluoride. Now, at my age, I grew up in a world without fluoride, and I had so many teeth removed. All of us had teeth removed all the time because we had rotten teeth, and
Right.
and they were constantly having teeth removed. Now it's almost unheard of now for kids to have their teeth removed. It's another thing we should talk about one day is the incidence of dental caries and general body pain and heart disease and how devastating it is for health to have rotten teeth. But Robert J. Kennedy isn't particularly interested. Maybe he thinks it's a plot. If he pulls back on big pharma, that's not a bad thing. You only have to go to America or Russia, for that matter, to see how many people are dying from drugs that have been prescribed by doctors. These people aren't getting illegal drugs; they're getting prescription drugs, and that is amazing. That the
There's a
drug
big
company,
fentanyl problem. There's a big fentanyl problem in America.
the company that supplies it is getting the blame. The kids who take it aren't, or the people who take it aren't getting the blame, and the GPs who prescribe it aren't getting the blame. But no one makes them prescribe it, so I think that's really interesting. But anything that pulls that back, fine. And like I said, the most profitable drug of all time are the statins, and behind that are the Nexium, the ones that reduce the acidity in the stomach. It's terrible the way that bodies are being treated, and people like my three sisters are all widows. Their husband, well, my sister-in-law and my two sisters, their husbands died in their 60s. My brother and brothers-in-law, and something's wrong. Something's really wrong that we're losing our men like this. And I had another friend die a couple of weeks ago.
Do you think a plate of food is as nutritious now as it was back in the 50s?
Oh, do not ever glorify the 50s and the 60s. It was shit. Everything was boiled with. It was rubbish. I don't remember the 50s, but I remember the 60s.
I'm not talking about taste. It wasn't the best. There wasn't the best
Well,
Lebanese food in town, but
that's right. I said that to you last time. You had Lebanese food, but when they replaced the olive oil with what is it? Not carotid oil, the other oils, the seed oils. When they canola oil. When they replaced, and that was a big thing. It was a big push to replace butter with margarine. My mother was utterly disgusted.
Go back a bit earlier then. Do you think a plate of food today is as nutritious as it was, say, 100 years ago?
I think so. It just depends on which food you have.
Yeah.
So
you don't think there's an issue with with pesticides and so forth, contamination?
They were using
food
DDT
contamination,
then.
and also, look, I had some fruit on the weekend, and there were these big strawberries, right? They were full of water. They were just full of water. They were just big for nothing.
Yeah,
and that's just
getting back to what I was saying about we're being told lies. We're being gaslighted. That's a nice big strawberry. It's not a strawberry. It's water with a strawberry coat on it. We're being lied to, and this is why I think society is really at risk, especially with your mate Trump, because. But what he did do is he did say to people, I will do something. Whereas the others on the other side, I really didn't follow it because it does my head in, but it was just saying nebulous things like, we're all going to be happy, we're all going to be fine, all that stuff. At least Trump said we're going to get rid of 11 million we're going to round them up and throw them out of the country and kill them if we have to. he gave them definite things to say. We're not hearing definite things. And that's doing people in psychologically, I think. But anyway, let's move on from that. I don't know. Our strawberries are good. Our lettuce
the question
is good.
the reason why I asked the question is, do you think that any of those, I guess, the things that happen in the States, do you think that some of that thought process or methodology or whatever it is, do you think that'll flow on to the rest of the West, to Australia? I mean, we're here. Let's talk about us. If Robert Kennedy is somebody who wants to pull back on pharmacology a little bit, I mean, they give I don't know, I think the rate of vaccination in America is massive. I think they do like something like 76 shots in their school years. And that's way more than what we do here. And do you think if things become a little bit more logical in the way that they're presented over there, do you think there's a flow-on effect to Australia in terms of health? Or do you think, are we more following the United Kingdom model?
Oh, the United Kingdom is pretty buggered up too, I must say. I mean, the NHS is a complete failure. I don't know. I think that America has been eating, I don't know, how often have you been to America? Have you been there?
I've never been there, no.
Oh, it's shocking.
But I hear stories.
The food
is
utterly inedible. Even the peanut butter or organic peanut butter has, sugar in it. The eggs are white. The yolks are white. It's just horrible food. And I think that it's a nation that's been destroyed by malnutrition. I remember in New York, this black fella sitting in the gutter saying, "Black people, they're trying to kill us through malnutrition." It was a big sign he was holding up, and it really struck me because by that stage I knew that this food was... And I came back, I'd only been away 2 weeks, and I had cracked cuticles, things like that. I think it really affected me. It's an unwell country. We're an unwell country in many ways, but not to that extent.
No.
I think we do know what good food is. No.
Yeah.
Thanks to the Lebanese and the Greeks.
On that note, I guess it's probably time for us to say goodbye. Thank you, everybody, for watching another episode. I plan on doing more of these with Anne, and I think this has been great because there was no script to this. We just kind of had a chat, and this is what we normally talk about. I think when me and Anne just catch up privately, this is how we chat. There's probably a few more expletives in there, but we try to keep it clean for everybody. All right, everyone, have a good evening, and thank you. Hang on the line with me, but everybody else, have a good evening, and we'll catch you on the next episode.
Love your work, man. See you.